Hello everyone, thank you for meeting with me today. We're just going to do an education session today. I'm going to be teaching you about getting our patients up and moving, specifically our ICU patients. I've always felt that we don't get our patients up as much as we should, and so I've been doing some research on it, and this is just a subject that I feel strongly about. And I know a lot of you are probably very hesitant about this subject because we already have a very increased workload as it is, and several tasks that we need to get done throughout the day. So adding one more task to our list of things to do during the day can be quite overwhelming. However, I feel like if we take baby steps and we just at least become educated about this subject, then we can slowly start progressing our patients and getting them up and moving more often. So, and I've also noticed that if we get a patient that was transferred from another unit, their physical therapy, if they have physical therapy, their physical therapy orders are discontinued automatically. I just learned that the other day. I did not realize that, and I was wondering why my patient didn't have physical therapy orders, and they had told me, well, anytime they're transferred into ICU, they're automatically discontinued, and the only way they can be reordered is if the doctor reorders them. So I feel like a lot of our patients kind of fall through the system with that. And even if our patients have physical therapy orders, they only come and see them 1, maybe 3 times a week. And although it's helpful and it's nice, but it would be nice too if we could get our patients up moving more on our own. It's really nice too when we have a patient that's transferred out of ICU, because our patients are so critical. It's really nice, a nice feeling when you see that they get better and that you see that they're transferred off the unit. But I've realized that, sometimes we always wonder what happens to these patients after they're transferred, and how does their quality of life improve, after they're discharged from the hospital. So after hours of research on this subject, I've discovered that if we initiate early mobilization for our patients in the unit, the benefits are just substantial, and the statistics and everything, it's just really, really great. So I also believe that there's a lack of knowledge regarding the capability to mobilize an ICU patient. Many people believe that an ICU patient is too ill to be mobilized or too weak to be mobilized, and that they need to be kept as immobile as possible to reserve their strength for healing and allow their body to rest. And although, yes, these patients do need their rest, and some patients, are too critical and too unstable to mobilize, but, not all of our patients fall into that category. We do have a lot of patients that we're able to move around. We just don't think of it. We get busy with our day, and, we're used to our patients being in bed all the time, and we don't think about getting them up and moving or even doing exercises in bed, something simple like that. Inactivity can have significant adverse effects on several systems of the body, including the brain, musculoskeletal, pulmonary, and as well as the cardiovascular systems. These adverse effects can lead to increased rates of delirium, decubitus ulcers, muscle atrophy, pneumonia, and DVT. In these patients that are deconditioned, this deconditioning results due to limitations that we place on these patients. Limitations such as the mechanical ventilator, sedation, orders for bed rest, and complications of their acute illness. What I found very surprising was how quickly this deconditioning can occur with these patients. One study found that it can occur in a few days of inactivity, with some reports indicating that critically ill patients can lose up to 25% of their peripheral muscle weakness within 4 days of being mechanically ventilated, and 18% of their body weight they can lose by the time of discharge. This functional disability can not only lead to increased rates of readmission, but long-term neurocognitive disability and delirium as well, which can persist up to years after discharge from the hospital. You know, some patients, it's common sense. It seems like, okay, they're going to take a long time, even years to recover, but it's surprising that some of our patients that just are on bed rest for even a few days, how weak they can become. And, you know, if we start getting them up and moving more frequently, then we can preserve that muscle and their strength and decrease the rates of delirium as well. So despite the research and evidence that immobility can have detrimental effects on the ICU patient, there are actually very few hospitals that are actually implementing and initiating effective early mobility programs. I did read about some larger hospitals such as Johns Hopkins. They have a mobility team. Now, we're a smaller hospital, so we're not really capable of having a mobility team, but they have just really found how safe and feasible it is to get these patients up and moving. And actually, the patients they've done several studies, and the patients that they're getting up and moving have less adverse effects than the patients that are immobilized and, you know, just given the standard treatment. So now that we know that immobility is harmful for our patients, what are the benefits of implementing a mobility program for our ICU patients? Mobility programs are an evidence-based strategy that has been demonstrated to be both safe and feasible, like my example with the Johns Hopkins hospital. And it has also been shown to reduce hospital length of stay, decrease delirium rates, and reduce costs for ICU patients. There's just numerous benefits to any type of mobility for these patients. Patients are also shown to have significant improvements in physical and neurocognitive short and long-term outcomes, demonstrating a better quality of life after these patients are discharged. So that would just make me feel so much better if, you know, these patients are getting up moving, and, you know, after they're discharged off the unit, you know, we see that they're stronger when they leave our unit, and they are less confused and less pressure ulcers, and just so many more benefits. So not every patient, like I said, is going to be able to be mobilized. Between, you know, the nurse and the doctor, they'll consider the patient's overall respiratory, cardiovascular, and neurological function, as well as the presence and location of any central or arterial lines. You know, obviously some patients, common sense, you know, for us, it's, you can't get them up and get them moving. They're just too unstable. But the ones that can, believe it or not, a patient having an endotracheal tube, they say, is not considered a valid reason to exclude them from mobility exercises. You know, some people think, oh, you know, they can't initiate any mobility because the patient is intubated, but that actually is false. They are still able to be mobilized. As Lorraine pointed out to me prior to this teaching session, she's been here on our unit for many years, and she said that she was telling me that years ago they would get their stable intubated patients up, you know, into the Jerry chair, and even if it's just sliding them over. But she said, you know, it seems like over the years, I think maybe because of, you know, our tasks that we have for nursing, we just don't have the time. You know, we're placed on so many different tasks and everything. So I've learned that some of you are visual learners, so I've created this poster here just to give you a visual with some of the facts that I was just speaking about.
Excuse me, Erin, before you get started. I think it would really be a good idea that we included physical therapy in our daily rounds. Right now, they are not part of our round team, but I think that having them there will perhaps get physicians to order physical therapy sooner and to get our patients up moving, even our intubated patients. What do you think?
I think that's a good idea, because they're not, right now, they're not included in our daily rounding, and I think that would give them, you know, a chance to evaluate the patients too, and maybe make suggestions. You know, sometimes we don't think that a patient could be mobilized, or we could do any exercises with the patient, and then, you know, they could suggest that.
Oh.
That's a good idea. Thank you.